In this video, we're going to cover a number of different pathologies to try to reinforce the normal anatomy of the abdomen. And so we're going to start out by talking about congenital diaphragmatic hernias. And there's two different types. The one that's represented in the image here in this young infant is called a Bowel hernia. So this is a larger, more common, and more posteriorly located than the Morgagni hernias, which are smaller and tend to be more anteriorly located. So the dark region that you see right here up in the thorax is indicative of the herniated bowels that have herniated up into the thorax of this infant. The mottled appearance that you see on this image, especially when you're looking at the large intestines, are indicative of feces. So again, that's a characteristic appearance of the large intestine. Obviously, we've seen where when it's more gaseous and not filled with feces, you can appreciate the haustra and other features of the large intestine. But in this case, when it's filled with feces, it's difficult to identify anything other than the mottled appearance. But keep in mind that is a normal appearance. You can also see on this one the mottled appearance down here in the pelvis, so that's just indicating again the presence of feces in the sigmoid colon and the rectum. But you'll notice a number of different hyperdensities on this image. So we can see over here where the hip fracture has been repaired. So you can see some screws that are put in down here, as well as the larger piece of hardware that was put in, the fixation device that was put into the femur to help stabilize it after a hip fracture. You can also see a peg tube right there, which we'll talk about more here in just a moment. And then down here, this is actually the bladder, and the reason you can actually see it is due to the presence of a very large bladder stone, and we'll talk more about that when we get into the pelvis lectures. So a peg tube, I mentioned that on the previous image. This is a better view of one right here, so you can see the external part of it and the internal part of it going into the stomach, or into the duodenum probably in this situation. And so PEG stands for percutaneous endoscopic gastrostomy tube. And so this is again a way to provide parenteral nutrition, or to provide nutrition, obviously without having to actually eat. So in intubated patients or somebody who's sedated, PEG tubes are fairly common in ICU patients. In this image here, you'll notice that there are some renal calculi right there. So that again, kidney stones is what we're seeing in this image. And then this is an example of what's called a staghorn calculus. And so this is something that we'll talk a little bit more about here in just a moment. And then you can also see these osteophytes or bone spurs in the lumbar region of this person's spine as well. This is an example of a staghorn calculus that's actually been removed. And then this is obviously a picture of the namesake of the staghorn calculus. So in this image, you'll draw your attention up here more superiorly, where you get a little bit more characteristic view of a staghorn calculus. So again, there's the zoomed in view, so you can see it, appreciate it a little bit better. And again, staghorn calculus is the name of that. And so this is a renal calculus that forms in the renal pelvis, and will oftentimes have the horned appearance arises from the fact that it has projections that are protruding into the minor and or major calyces. The kidneys are usually about 10 to 14 centimeters in length, so you can see one that is circled over here. Again, on abdominal chest or abdominal x-rays, abdominal films, typically the inferior margin of it is much easier to make out than the rest of the kidney. But again, this is the approximate size that you'd expect for a kidney. And then the dome of the bladder, so the bladder, remember, is anterior, just posterior to the location of the pubic symphysis, and the dome of the bladder is located at roughly parallel with the acetabulum. So of course this is the acetabulum right here where the femoral heads are sitting, and so the dome of the bladder should be approximately at that level. But again, keep in mind that can change quite drastically depending on how full or empty the bladder might be with urine. In this image here, you want to be looking at the bowels and trying to determine if they're dilated or simply distended. And so in this case, and you also want to identify whether this is large or small bowel. And then we'll talk here in a moment about whether air is present in the sigmoid or the rectum. But in any event, this is all these loops of bowel that you're looking at. These are all small intestine. You can see the plica circularis quite well, but you do have a relatively dilated loops of bowel here, and so you'll notice the air fluid levels, which are not necessarily abnormal, but in this case they are indicative, based on the patterning, they are indicative of a small bowel obstruction. So again, this is a 59-year-old man. He had a previous history of small bowel obstruction about 3 years ago, and once again we're seeing that again in him at this point. So in this image, what you want to be trying to do is differentiate between large versus small bowel. So here you can clearly make out the descending colon moving into the sigmoid and rectum, so you can see the gas down there. And then these are some clear loops of small intestine where, again, you can see the plicae circularis quite well. So again, these are just good practice images for trying to identify small versus large bowel. Here's another example where the upper arrow here is pointing out the large intestine. You can see the haustra quite obviously, and then here you can see the plicae circularis also quite notably throughout most of what you're looking at in the central part of the abdominal cavity in this patient. This is an interesting film where we're looking at a scenario which is known as the string of pearls sign. So this is also a sign of a small bowel obstruction. You can see an air fluid level located right here, which oftentimes you'll see. You can also see one up here, which is in the stomach. But the string of pearls sign is where small gas pockets get stuck between the plicae circularis when there's a small bowel obstruction. And so this is a very clear sign, diagnostic sign of small bowel obstruction. Same thing here, we're once again seeing an air fluid level, but you're also noticing a very dilated small bowel at this point. You can see the plicae circularis throughout the small bowel right here. And so this is, again, a clear sign, along with the string of pearls sign right down here. So this is a very evident case of small bowel obstruction in this patient. Here's another one, another image where you can get some good practice at trying to identify small versus large bowel. So looking right here, hopefully you can clearly make out the fact that these are loops of small bowel, so small intestines. So there's also something known as free air, or a pneumoperitoneum, that will oftentimes, in an upright individual, it's going to show a small space in between the diaphragm and the liver. So it's usually easiest to see on the patient's right. The left, it's somewhat harder to be able to differentiate, just because in an upright individual you have obviously the stomach there, the fundus, which is sitting right underneath the dome of the left diaphragm, hemidiaphragm, and so it can be a little bit harder to make it out on that side. But here on the right side of this patient, you can clearly make out a pneumoperitoneum. So there's a number of different causes of that, but again, it just gives you a good sense of the structures that you're looking at here with the diaphragm versus the liver right below it. Here's another example of pneumoperitoneum, or free air. So again, here's the diaphragm. You can see how there's this sort of pouch of air in between the diaphragm and the liver, which again you should not normally see. You can also actually see it over here on this side. So this is a bilateral pneumoperitoneum in this case, which obviously the abdominal cavity is able to communicate across the midline, so that's not surprising, but in this case it's just you're able to visualize it very well on the left side. And you can also see part of the large bowel located right here, so you can see the wall of the large bowel, or of the colon right there. In this image, once again, we have a bilateral evidence of free air, so of a pneumoperitoneum, shown by, so the diaphragm's outlined by the yellow arrows, and then the orange arrows here are pointing out what's known as Wriggler's sign, and this is where you can very clearly make out the wall of the large intestine. So normally you're not able to make out a clear differentiation between the luminal side and the extraluminal side of the intestine, but in this case obviously you can, so that's a clear sign of free air in the abdomen. Some more examples here. So you can see, once again, bilateral evidence of air underneath the diaphragm, so pneumoperitoneum, and then Wriggler's sign, where you can clearly make out both sides of the kind of translucent sides of the wall of the bowel right there. And then same thing over on this side. Once again, you can make out these clear lines on the walls of the intestine. So this is going to be examples of small intestine in both cases right here. And so again, that's called Wriggler's sign. I think we see more of that here momentarily. Another sign of free air in the abdomen, this is going to be most likely in a supine patient, but you'll notice the orange arrows both on the left on this AP view, and then on the right of a CT, where you can see this line that's pointed out. So this is the falciform ligament. So normally you can't see the falciform ligament on abdominal CT or X-ray. But of course, if you get abdominal distension as a result of pneumoperitoneum, then it does become visible at that point. So once again, we have evidence of bilateral pneumoperitoneum in this case. You can also see large bowel quite clearly over here. And then again, we have wriggler sign, which is again a evidence of a pneumoperitoneum. So now shifting our attention to the kidneys for a little bit. So we're looking at, this is a IV pyelogram. So basically the patient is given a radio or an iodine-based tracer, and as it's filtered through the kidneys, you're able to take repeated x-rays to be able to demonstrate whether or not it's able to filter all the way through the kidneys to the ureters and ultimately into the bladder. But you can see clearly the renal pelvis here, the ureters as they're descending down into the pelvis, and then the urinary bladder located down here. And so there's a couple of different sites for ureteral stone obstruction. And so you want to kind of keep an eye out for those locations when you're looking for potential calcified or calcifications, which are going to be the kidney stones that might block the ureters. And so we have the UPJ first, which is the ureteral pelvic junction. So that's going to be not the bony pelvis, but the pelvis of the kidney. So the ureteral pelvic junction is located right here. So that's going to be one, obviously a clear or obvious site for a stone to potentially get lodged and cause a blockage. The second location is going to be down here where you are moving across the common iliac arteries and moving down across the pelvic brim. So throughout that region, that's another common site for ureteral stone obstruction. And finally, the UVJ, which is going to be the ureterovesicular junction. So the ureterovesicular junction, vesicular refers to the bladder. So intravesical, vesicle usually refers to the bladder. And so this is just the junction between the kind of the end of the ureter and then where it's dumping into the bladder. That's another potential site for obstruction. So this is a young patient, a young adult with mononucleosis, and about 75% of individuals with mononucleosis end up developing splenomegaly. So you can see right here where that orange arrow is. I'm going to remove it just for a moment, but you can see this very enlarged spleen in this patient. So you gotta have to be a little bit careful not to confuse that with a kidney, but based on the location of it, you should be able to differentiate that spleen from a kidney. Here's a patient with an NG tube or a nasogastric tube, so you can see it coming down through the esophagus, into the stomach, around the duodenum, also to its ultimate site of resting. And so again, that's a properly placed NG tube. And you can also see these ureteral stents that have been implanted bilaterally in this patient. We mentioned earlier phlebolyths, so we're looking at another example of a phlebolyth right here, just pointed out by the orange arrows. Something to keep in mind with this is generally the center of a phlebolyth is going to appear radiolucent. So just like this caricature drawing up here represents that, oftentimes you'll see that sort of appearance to a phlebolyth, and that's one way that you can confirm it. Same thing with the comet tail sign that you can also look for on CT, which we'll talk about in the next lecture. So here's an example of something known as hydronephrosis. So hopefully you can make out the kidneys. Here's the right kidney and the left one over here. And so you can see there's this massive swelling effect that you have over here. And so that's indicative of a ureteral calculus. So again, a kidney stone that's blocking the drainage of urine and causing this hydronephrosis. So in the next image in the series, you can see the clear location of that obstructing kidney stone. Here's another example of a kidney stone. So not particularly easy to differentiate on this image, but you can definitely make out the fact that there is a hyperintensity there. Another pyelogram here where you can see the renal pelvis on both sides, as well as the ureters as they're descending down into the pelvis. And so keep in mind the basic location of the ureters when you're looking at these images. That's going to be where you want to be looking for the presence of renal calculi or ureteral calculi that might get stuck there. So you'll be looking for these hyperintensities located throughout this course. And so the transverse processes of the lumbar spine are going to be a good landmark to use when you're looking for the course of the ureters. Here's another example of a renal calculus. So again, a kidney stone located right there. And then looking at this image, you might notice that there's this large appearing structure located right here. This is a AAA, or an abdominal aortic aneurysm in an older individual. And so typically these aren't, the abdominal aortic aneurysms are not visible on an abdominal x-ray until they get larger than about 3 centimeters. And usually if they're larger than 5.5 centimeters, that's the point at which surgical intervention is necessary. And the way that we typically treat AAAs or abdominal aortic aneurysms is to implant bifurcated endovascular grafts. And so you can see here an example of a bifurcated graft where, again, you can see how you have the basically the end of the terminal part of the aorta where it bifurcates into the common iliacs. And so here on imaging, you can see this same exact implant in a patient. In this person, you can see a radio-opaque mark visible in the pelvis. And one thing that you'll note about it is that it is mobile, or it's mobile, so it can move around within the bowel of this patient. So trying to figure out what that might be, it turns out that it was actually surgical gauze that was left in this patient. And so they surgically went in to remove it from the ileum, and there you see it being pulled out from the ileum, and there it is. There's that surgical piece of gauze, surgical gauze. And so, again, this has obviously been a subject of significant concern in the medical community. And so that's one of the reasons that now we spend so much time counting surgical sponges and needles and other things in the OR, is to prevent stuff like this from happening, because it does cause very significant morbidity in patients. Not typically a fatal mistake, but it can cause very significant side effects for the patient. And so your vocabulary for today is, this is called a Gaussiet pyboma. And so that's a mass within the body composed of a cotton matrix surrounded by a foreign body reaction. And so that's what you get from a surgical piece of surgical gauze being left inside of a patient surgically. So Gaussiet pyboma is your word of the day. All right, we'll see you guys next week.